Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. This is Dr. Andy Cutler, and today we have a very important topic that I don't think we can talk enough about. We're going to be talking about Alzheimer's disease, but in particular, updates on diagnosis and emerging treatments, currently available on emerging treatments. And with me today is Dr. Dani Cabral. Dani, how are you?
I'm great. Thanks for having me.
Thank you so much. Dr. Cabral was part of the faculty at our recent NEI Congress, and your talk was terrific, and the information's well received, but we want to extend it maybe to some people who were not able to attend. So let's get started, if we could, maybe just with an overall kind of definition. We talk about dementias, and there are multiple types. What do we mean when we're talking specifically about Alzheimer's dementia?
So I'll start with the broad definition of dementia. So it's progressive trouble with one's thinking and or memory, usually in older adults, that eventually leads to trouble with function that also then continues to evolve. So with the development of biomarkers, where we can now look for the biologic causes of dementia in the brain via neuroimaging, so brain scans, cerebrospinal fluid, and almost with blood ready to go, we know that Alzheimer's disease dementia typically starts with that short-term recall where the person, just maybe keeps repeating the same thing, having trouble in areas that they typically have been well versed in, remembering things, and so that can also include other areas of thinking, but that's typically the starting point for Alzheimer's dementia symptoms. Now this whole field is getting much more complicated because of us now moving towards a biologic definition of Alzheimer's disease. And so and you're asking a question about the symptoms of the disease. So I'll stop there and see, I bet we're headed into those other arenas.
Well, sure. As mental health professionals, we often get involved with the behavioral symptoms. And I noticed in your definition it was more about thinking and memory, but there are associated neurobehavioral symptoms as well, correct?
Oh, absolutely. And I feel embarrassed for not mentioning that to start. But in fact, we know that is all sorts of neurobehavioral symptoms can occur, everything from anxiety, depression, irritability, apathy, psychosis, agitation, and in fact, almost everyone who has Alzheimer's will have one or more of these symptoms throughout the course of disease, and most of them have multiple going on simultaneously, which, as we know, is the most challenging for care partners and families, and leads to early institutionalization, more hospitalizations, more medications, and tougher for the care partner. So, and now what's really interesting is because of the biomarkers, we see that in a subset of Alzheimer's individuals, they actually start, their first symptoms of Alzheimer's are mood changes, neurobehavioral changes. And
interesting.
Yeah, and so knowing that those, the amyloid beta plaques in the brain start building up, so that's one of the primary first hallmarks of Alzheimer's disease, start building up 25 years before any symptoms. And so we've now found that some people do have those mood changes happening at the very beginning, maybe even, in their 40s and 50s.
Oh, my goodness. Isn't that something?
Yeah.
Well, we have talked in the past, of course, about, pseudo-dementia, but it may be that people with depression who develop that may actually be a form fruste, or maybe predicting that they will go on to develop dementias.
Absolutely. If there's no provoking factor for the depression, then that could absolutely be what's going on.
Yeah. Well, this is obviously a whole nother talk we could have.
Yes.
We're going to focus today, of course, more on the cognitive and the diagnosis and treatment of the Alzheimer's disease per se, and the excitement around potentially disease-modifying agents. The area of neurobehavioral treatments is also evolving rapidly, and there are a number of drugs in development for that, but that's for another day. Okay, you alluded to this these definitions evolving, what would you say is the current thinking around the term early Alzheimer's dementia?
So the definition I'd say for early is really, we can divide it into what is the Alzheimer's research, researchers say, and then what do clinicians say. So
Yes.
Clinicians generally, and that's mostly primary care providers, right, who are caring for people with dementia, still, I think, would define early Alzheimer's disease as those who have the beginning symptoms. So that would be those with mild cognitive impairment or mild dementia due to Alzheimer's disease. And so just to define those, so mild cognitive impairment is when there is more trouble with thinking than we'd expect for one's age, but they're still functioning independently. Okay. And then mild dementia is when there is a little bit of functional decline going on, where families and friends might have to step in some areas to help out. So that's still the general feeling about what that means. But on the research side, it is very different, and it's because of what I mentioned about us now knowing that the Alzheimer's brain changes start decades before any symptoms. And it appears, and we'll talk more about this in a bit, I'm sure, but these emerging treatments of the anti-amyloid monoclonal antibodies, the data coming out from these phase 3 trials shows that it does appear the sooner we can treat these diseases, the greater slowing of cognitive decline happens. And so there is a push to shift the overall understanding of early Alzheimer's disease as being before there's any symptoms. And so what we call that is, they're calling it preclinical. Yeah.
Yeah, so that would be when there's biologic markers suggestive, but not yet clinically apparent. Is that?
That's exactly right. And I always make the analogy to another broad field of cancer, where we identify cancer, we try to, with screening tests by our primary care doctor ordered, like colonoscopies, mammograms, before there's any symptoms. And so that's where the Alzheimer's field is moving.
Oh, I like that. That's a terrific analogy. I think our clinical audience would really appreciate that. Okay. We all know, we're all sort of trained on the mini mental status exam. Are there other screening tools available that can be used in the clinic?
There are a number of cognitive tests that can be done, that some for the patient and some for the care partner or informant. And we're trying to find that balance of being comprehensive in our assessment of one's thinking and function, but also, time, doing it quickly. And that's always going to be the best for especially the primary care audience. And so I would, the counterpart to the MMSE would be the MOCA, the Montreal Cognitive Assessment. And that's been around for many years, well validated. It's free. It's in many languages. It takes about 20 minutes to do, typically maybe less, in a less impaired audience population. And now they have there's different versions. So there's versions that are adapted for the hearing impaired. There's one for vision impaired. There's one for people who have significant or are illiterate, basically. There's a telephone version, a video version. And so that I think is actually, in many ways, it's seen as superior to the MMSE. For those reasons, and also because the MMSE is proprietary technically, so we are supposed to pay for it. And then the MMSE, for those who have done it, has many points out of 30 points. Many are for orientation, and many are and then otherwise for that short-term recall, where they give you 3 words and you give and ask to repeat them later. And I always, we work with older adults, right? And so when I'm asking someone who's retired and who lives in the Phoenix area, like, what is the season, right? And the sun is shining, or what is the date or the day of the week? It's like, it's irrelevant. And so the MOCA doesn't have quite as much emphasis on that, and does have more questions for executive function. And that's really important as an early detector, especially for people who are more well-educated and can manage to remember those 5 words or 3 words more readily. But when you're asking them to keep track of many things and multitask, basically, that's where some of the dysfunction can be unmasked. So other Other cognitive assessments are something called the AD8, and that's an informant-based questionnaire that can get at identify, whether there might be dementia present. So it's not going to pick up on that. Subtle changes early on in disease, but can identify dementia. There's the mini cog, which is nice. So that's free. That's really quick, and so that's where we have a list of words given to remember. Then you draw a clock, and then later you're asked to repeat the words. And so that's very accessible to the primary care audience, providers to do that in the clinic. And then there's one other that I might mention called the QDRS, the Quick Dementia Rating Scale, and that is quite comprehensive and well validated. And there's a patient version and an informant version. And so if you have a little more time, that's going to be a good one to pick up on both cognition and function. Yeah.
Yeah. I consult with pharmaceutical companies, and I reviewed a number of protocols for new medications recently, and I see the MoCA being used quite a bit, and occasionally some of the others as well. So thanks for that listing. Well, let's move into now some of the newer diagnostic techniques. And in my simplistic way of thinking, and help me with this, I put them into a couple of buckets. I think of neuroimaging techniques, plasma or blood, and CSF markers. So is that, first of all, a good way to organize this, and what would they be?
Yes.
So let's walk through some of those. So
if someone's coming to see me in the clinic with cognitive concerns, the main diagnostic tests are going to be, we're going to do blood tests to rule out reversible or treatable causes of cognitive change, and those mainly include thyroid, TSH, B12, basic, electrolytes, kidney function, and then we're going to do neuroimaging. So really, the MRI of the brain without contrast is far superior to a non-contrast head CAT scan. So with the MRI, it is just in general with brain imaging. Many providers still do not image the brain in someone who has cognitive concerns, and this needs to change because we're talking about a brain disease, so we need to look at the actual organ, right? And so what we're looking at when I would order a brain scan, so I'm looking for anything surprising like tumor, stroke, brain bleed. We do see these meningiomas that can be pretty big. They're rare, but they can happen, and that could be the cause. So we must do these. And then otherwise, we're looking for shrinkage in the brain or atrophy, and specifically in the short-term recall center. So that's the hippocampus in the medial temporal lobe. So that's a non-specific marker of Alzheimer's disease. So if you have a 65-year-old coming in with progressive memory loss, short-term recall issues, hippocampal atrophy, there's a high chance that person has Alzheimer's disease. Now, so that's mainly still what's happening clinically. Now, if you're in a specialty center, we're going to be able to get some more specific biomarkers. And so cerebrospinal fluid is really is a good one, and that's been around for a while, but a lot of people, for various reasons, aren't going to be getting lumbar punctures. But with the cerebrospinal fluid, or CSF, we can look for a lot of things in that one sample of fluid. So that's the amyloid and the tau. And so I can go into the total tau and the phosphorylated tau. And then that is covered by Medicare and payers, still only for the indication of whether we're thinking it's Alzheimer's versus frontotemporal dementia.
I see.
But it seems that that might be changing. They might be more open to paying for other indications given these treatments that are being approved. So then,
can I just ask real quickly, how does that test distinguish between Alzheimer's and frontotemporal?
So you're essentially trying to rule out Alzheimer's disease. So it's testing for the amyloid and the tau, the Alzheimer's panel. And so if it's abnormal, then it's Alzheimer's, and if it's normal, then it might be frontotemporal dementia.
Got it. And can that MRI also help with that? I mean, I imagine you'd see more shrinkage in the front parts of the brain.
You actually may not see that until well into the disease, into mild to moderate dementia due to those neurodegenerative diseases. Better for that in terms of neuroimaging is an FDG PET scan.
Okay.
So we do order those for that indication also.
And what does the FDG stand for? I think a lot of us know PET.
So FDG stands for fluorodeoxyglucose.
Okay, got it.
And so we are looking for glucose metabolism.
Right.
And so we see low glucose metabolism, decreased or hypometabolism in different neurodegenerative diseases. And the way I describe this is this is a proxy for energy usage in the brain. Sure. And so the patterns we see are with Alzheimer's disease, we see hypometabolism in the temporal and parietal lobes. Mm-hmm. In frontotemporal, of course, we see frontotemporal hypometabolism. And then in Lewy body disease, we see parietal and occipital, so back of the brain. So we think about, a good way to think of that is the occipital lobe is the visual cortex, and Lewy body disease often has visual hallucinations.
Yes. No, that's very helpful. Yeah.
And then, so those have been primarily what we've had available until just, I think it was last month when Medicare said they would pay for amyloid PET scans.
Oh, my.
So this is huge, and
yes,
this is a result of this drug lecanemab or Leqembi being approved. Right. And I think that's really what prompted Medicare to be willing to pay for this expensive PET scan to look for amyloid building up in the brain.
Got it. Now, those tests are almost always done in the research protocols that I've seen, but obviously they were paid for by the sponsor of the study, not by Medicare. So that is a big development. All right, so we have these neuroimaging techniques, and thank you very much for walking us through that. We talked about CSF. How about blood or plasma markers? Yeah,
so the blood tests for Alzheimer's disease are now really well validated, and they're not, though, yet paid for by insurance. Okay. So around 2020, there was an FDA, they were a breakthrough designation for the Alzheimer's blood test to look for the amyloid beta, and that was specifically to be used for people who are symptomatic. Now, it's not clear when payers or Medicare will be willing to reimburse for the blood test, but that's going to be a game changer, right? When providers can just easily order these blood tests. At the same time, though, there's a lot of considerations that need to be brought forth because, for example, what are we going to do with these results, right? So suddenly we have many more people who have Alzheimer's diagnoses. Do we really have the care and treatment for everybody? So
yeah, especially picking them up so early. I see what you're saying.
And can I just mention quickly about the blood test is that it's seeming that surpassing the amyloid blood test is the tau, specifically phosphorylated tau or p-tau. There's 181 and 217. And interestingly, that tracks with amyloid elevation in the brain. So for example, a person coming into an Alzheimer's treatment trial is going to get the p-tau 217 blood test to see if they have that abnormality. And so that, if they do, that would correlate with an amyloid PET scan. That would be positive. So it's a really much more easy and efficient and quick way to get people into clinical trials.
And that's a blood test, you're saying?
That's a blood test, yep.
Yeah, so we have blood tests potentially for amyloid and then p-tau coming later, I suppose. That would be great to be able to do blood tests rather than LPs, of course, which are harder to do and not available in as many places.
Right.
Are there other such tools or techniques in development?
There's other biomarkers being looked at, for example, retinal imaging to look for amyloid in the eye, which is cool because that's non-invasive. Yes. And then skin punch biopsies are being done to look for the Parkinson's protein, and also that's the Lewy body protein, the alpha-synuclein. So shifting to that really challenging, group that needs good diagnostic measures. Those are the main ones so far.
Okay. Now, assuming we've done our testing and we've decided we're going to monitor the progress either by itself or with treatment, what are the best tools? Which of these tools would you use to monitor progress?
up until the recent approval of lecanemab or Leqembi, we would not continue to do any of these these tests because it really wouldn't change management. The only reason we might do, say, once we've diagnosed Alzheimer's disease, we see the biologic changes, say, in the CSF. Unless there's symptoms of a new brain disorder like stroke-like symptoms where we would want to get brain imaging, we wouldn't repeat these tests typically because we know that the brain will slowly atrophy over time, and we are going to continue to do the same kinds of treatments regardless.
Well, that makes perfect sense, I guess. So until we have even more treatments, I guess. But you mentioned this new treatment, so we're going to move into that. Are there any other pearls of wisdom perhaps you might give our clinical audience on diagnosis, screening or diagnosis here?
Something that I'm finding really challenging to wrap my brain around is that we now know that most people who have a neurodegenerative disease of aging causing dementia also have another one, or maybe even three, right?
That's what I've heard, yeah.
Not to skirt around your question, but it's looking like maybe 40% of individuals who have Alzheimer's disease in their brain at death also have Lewy body disease changes.
Oh my.
Those who have Lewy body disease, primary diagnosis in their brain at death, maybe about 2/3 have Alzheimer's disease in their brain. And so what I'm getting at is there's mixed pathology in many people. And so what I would say is that just identifying that someone could have one of these starting up in their brain should elicit, ideally, a workup for a diagnosis. And there's many reasons why it's important to have early diagnosis, which I can go into if that would be helpful. But then probably I would say to think about with Lewy body disease, that's a really challenging one, and an early diagnosis would be beneficial. I describe it as there's a combination of Parkinson's-like symptoms and then the progressive dementia, but maybe most importantly is there's commonly, even more than in Alzheimer's, there's neurobehavioral changes. Yes. And they can be very challenging, including these visual hallucinations that can be very distressing. And so if you think about someone has these visual hallucinations, they're having trouble walking, they're having maybe autonomic dysfunction, so they're cold sometimes and they're sweating sometimes, their blood pressure just drops suddenly, and they're having the progressive cognitive changes. That is so challenging, and they often end up on tons of medications even before they go for a diagnostic workup. And so when I see someone new into the clinic and they're on 6 psychotropics for different things, and I say, they could definitely have Lewy body disease. So that's something to keep in mind. And then with frontotemporal disease, that is one, the behavioral variant, whereas often in younger people, so people in their 50s, usually when they're presenting, or early 60s, and they have these loss of empathy, loss of insight, acting impulsively, recklessly, doing things that are completely out of character, and often end up in the inpatient psychiatric unit, but they're still strong and capable, and their memory's good, and a lot of their cognitive domains are good, and so they can talk them, they can help, they can justify what's going on, and so it takes a lot of time to get that diagnosis. So that's what I would say about those. Well,
that's really helpful. I mean, that makes sense. If your frontal lobes are affected, obviously it's going to cause all those symptoms you're talking about. And just quickly circling back to Lewy body dementia, the challenge, of course, with hallucinations is we're going to want to use antipsychotics, but these people are exquisitely sensitive to the motor side effects of these medicines.
Yes. And, this is where using cholinesterase inhibitors is so effective often for so many things with Lewy body disease. And I don't think many providers realize this. And so there's, cholinesterase inhibitors, so donepezil, rivastigmine, and galantamine. These are safe medications. They've been around a long time. People don't get really excited about them, but they should with Lewy body disease because there's more of a cholinergic deficit in Lewy body disease than is in Alzheimer's disease. They can, in fact, improve So then there's more of a robust response to cholinesterase inhibitors often cognitively, and they can lessen or even obliterate the visual hallucinations. So this is the one time in clinic, there's a lot of sad things that come through my clinic, but the one time sometimes I feel like, wow, I've really helped is when someone with Lewy body disease gets all the benefit and their family comes in and says, the old Larry's back, they're doing really well. And so.
I was not aware of that. I'm sure many of our audience members were not aware of that either. So thank you. That was terrific. Well, you're leading us right into our next area, which is, of course, treatment. And you've already talked a little bit about the cholinesterase inhibitors. So currently we have those three, but there are different formulations. So let's do those first, and then memantine, and then we'll talk about the next phase, the amyloid drugs.
Sure. So the cholinesterase inhibitors were studied and are indicated for any stage of dementia. Now, they are often used in mild cognitive impairment also, because that's just along the spectrum. And so what these do is modestly slow down the progression of cognitive decline. And it really varies per individual if you will see an overt response or not. But the way I describe it is you're going to be a little better off down the road if you're on these, rather as opposed to not being on them. And they're safe and well tolerated. And so the main side effects we see are stomach upset, GI issues, nausea, loose stools. There is weight loss that needs to be kept in mind. And if there's weight loss happening with no provoking factor, then I would try to go off of the cholinesterase inhibitors and see. And there's also rarely vivid dreams can happen, and sometimes slowing of the heart rate. So those are things to keep an eye out for. But everyone deserves a trial of these, and I know that people don't get excited about them, but I think providers don't. But I think the benefits far outweigh the risks, and I don't just think that. That's been shown over and over again in trials and real-world data, and people deserve a chance. And I think it's part of our ageist culture that leads us to not give people a chance. That's my...
Well, also, as you mentioned, they've been around a long time. They're not that sexy, I guess.
Yeah.
And people would, obviously, the Holy Grail is disease modification and all of this. Between the three of them, are there any differences that are clinically relevant?
Typically the first line is donepezil, and it's there's now a patch form that lasts a week. You change your patch once a week. And then what I found is that the others are comparable, but and with the rivastigmine, there is a patch version also. And so the good part of that, of course, is if someone's having GI issues from the pill, from the donepezil, we would try the rivastigmine or Exelon patch, and that often will not cause the GI issues to recur and can be really effective. And actually, it has a more potent max dose than the donepezil pill. And then otherwise, I found that if someone has side effects from donepezil, it's hard to know whether or not they will from the oral formulation of galantamine and rivastigmine, but it's worth a shot if they're noticing benefit and they want to continue.
The patch seems like a particularly good option. You're bypassing first-pass metabolism in the whole GI situation, and obviously for some people with Alzheimer's, that's a pretty convenient way for the caregiver to know that they're getting the medicine too. You can see that the patch is on and this kind of thing.
Definitely, and a week-long version is nice too, because then you don't have to worry about changing them daily.
Yeah, and you live in Phoenix and I live in Florida, and I have to tell you, some of these patch formulations are pretty good. They stay on even if you're sweaty or swimming or things like that.
Yeah, and that brings up, so the main side effect with the patches is the local irritation from the adhesive,
Okay. All right, where does memantine fit into our armamentarium?
So memantine is indicated for moderate to severe dementia. The studies have shown that it does not benefit people who are earlier on. And
I didn't know that.
So it's not recommended to start that earlier, and you might just be exposing people to possible side effects. So memantine has been shown to slow the functional decline modestly over time, and the typical form is a twice-a-day form. That's titrated over a few weeks to the max dose of 10 milligrams twice a day. most people tolerate it really well, and which is great given some of them have severe dementia and could be more sensitive to medications. But main side effects we see are constipation, and sometimes people, a small group of people become suddenly really agitated with memantine. Now, it is a small group, but it can be dramatic, and so I always counsel patients about that. And then we've seen sometimes people can just feel off, it's hard to define, and so what we've seen in secondary analyses of clinical trials and real-world data is that the memantine and the cholinesterase inhibitors can delay or lessen the severity of neurobehavioral symptoms also.
Yes.
And so I've seen that more commonly even in patients who are more in the severe dementia, and their family members just say, they seem just more calmer or more content. And that's huge. So.
Yeah, it sure is. And you can use those together, memantine and the acetylcholinesterase inhibitors, correct? Yes,
absolutely. That's pretty standard as the disease is progressing, to use both.
Right. Memantine's fascinating. It's an NMDA receptor antagonist, sort of a weaker one, if you will. And over the years, I've been consulting with companies who've thought about looking at it for mood disorders. Remember one time we almost did a bipolar disorder trial with it. It sort of didn't pan out, but it's just interesting to see it hanging around. Now, isn't there an extended release version, or is that not used as much?
There is. There's an XR version, and there's a combination donepezil memantine of the max doses. That is more expensive still. So
that's what I was thinking. Yeah, the cost. Okay. All right. Well, let's move on then to the monoclonal antibodies. There are actually two on the market, one a lot less used than the other. So maybe you could tell us a little bit about that. And then if we have a little time at the end, I really would like to talk about some of the things that are in development, because there's some really cool stuff in development too.
Yes.
So maybe just tell us about the two that are available now.
So in a couple years ago, the first, we're still calling it disease-modifying treatment for Alzheimer's disease.
Okay.
That's targeting the beta amyloid in the brain.
Right.
Was approved by the FDA to great controversy. So that was that's called aducanumab or Aduhelm by Biogen. So in short, the phase 3 trials, there were two going on at once, Engage and Emerge. One showed that there was clinically significant. They both showed that it decreased the beta amyloid significantly in the brain. One showed that there was clinically significant improvement or slowing in the cognitive and functional decline, and the other one didn't. So they halted the study. Biogen said this doesn't work. But what they did, they went back and reanalyzed the data, and they noticed that there was discrepancies between the two trials, where the one that showed overall benefit or positive had more subjects on the highest dose of the drug, 10 mg per kg, and for a longer time. And so in thinking about, good trial design, using the right dose, we learned a lot. But what happened was the FDA approved the drug based on the one positive trial, and then, there was uproar that this is not strong enough data for us to, pay thousands and thousands and millions of dollars for this drug. So Medicare ultimately decided not to reimburse for it. So it's not used for that reason. So then more recently, earlier this year, lecanemab, a similar drug, or Leqembi, which is developed by Eisai with Biogen, was approved by the FDA, first via accelerated approval based on the phase 2 data, and then the phase 3 data led to the traditional approval recently, or a few months ago. And so this is an anti-amyloid monoclonal antibody. It's an every 2-week infusion, IV infusion, though they are studying a subcutaneous formulation, and that's looking good. And so,
interesting.
So basically, what this targets the amyloid protofibrils, and it effectively normalizes the amyloid beta in the brain, and does show that in the 18 months of the phase 3 trial, there were 17 subjects, half were on placebo, half were on active drug. The ones on active drug had a 27% slowing of cognitive and functional decline, as a counterpart to that amyloid lowering. And then that's, and besides that, some of the other subscales they're looking at, better quality of life, lower caregiver burden for those on the active drug. So this is a big deal, and this is
Very
now
significant.
paid for by Medicare. Just starting to get prescribed. It's a real. It's going to require new systems to be developed to safely prescribe and monitor this, largely because of the potential serious side effects that can happen. So
Right.
I'll talk a little bit about those.
Before you
Sure.
do, does it also affect the tau or the neurofibrillary tangles? You've talked about the amyloid.
So it does appear to lower the tau also.
Okay.
Yeah.
That's great. All right. Well, let's talk about the elephant in the living room here. What are these
So let me
serious
just
complications?
correct that.
Sure.
Doesn't build up as quickly. The tau
Okay.
does not build up, right? So.
Okay. So it does affect that too. Yeah.
Yeah. So the big concerning side effects of all of this class of drug it's called ARIA, ARIA, which stands for amyloid-related imaging abnormalities. And so it appears that with the removal of the beta amyloid, probably for multiple reasons, there can be blood or fluid shifting out of the blood vessels. And so it's not clear that whether it's, because in those who have amyloid building up in the brain, it builds up also around the blood vessels. And so if you're pulling out the amyloid, it's destabilizing the blood vessels. Or it could be, the ARIA could be an inflammatory reaction to the drug, or maybe a combination. But so what you're going to see, what we've seen in the trials, is that this causes microhemorrhages in the brain. It can. And also this can cause edema. And it's usually they're together, these two things, when they occur in the brain. And so in the trials, the way that over many years of studying this class of drug, we found that we can usually catch it early before it's symptomatic by doing serial MRIs of the brain.
Okay.
And then if we see these changes, then we can potentially, we may have to pause the drug. There's different ways depending on how severe it is.
So my understanding is there's two types. There's the ARIA edema, or E, and the ARIA H for hemorrhagic.
Right.
Is that still true, or are we just seeing them as more kind of mixed?
So
they're
still separated out in terms of when we're looking at MRIs and trying to identify these, but we also are identifying whether there's what we call superficial siderosis, which is basically when the H, the hemorrhage or the bleed, spreads a little bit, so you kind of see it in almost like it's going along the curvature of the gyrite. But it's all caused by the same thing, and we do see, again, the H occurring a lot in the same geographic locations in the brain as the E. And so I think that's a great question. I don't think we know enough to really know how they're different and the same.
But the management is similar, as you've said. It's sort of watching and slowing down on the treatment. My understanding, too, is most of them are asymptomatic. Is that right? But they can cause significant symptoms.
Right. In the trials, the majority were asymptomatic or mildly symptomatic. Now, there are some times when people would go on to have seizures, and there were some deaths that occurred in both trials. Sorry, I didn't mention the other drug, donanemab, which is potentially going to be approved also, but similarly can cause these side effects.
Got it. And it's also a monoclonal antibody against the beta amyloid. So it's another one in that
That
class.
one targets the amyloid plaques. Yep.
Got it. So this is what earlier, when I was asking you about monitoring treatment, and you said, well, there is a situation with the newer drugs, so it sounds like now you routinely get MRIs, not PET scans, is that right? You'd use the MRI?
So potentially both. So the MRIs must be done if we are prescribing lecanemab or Leqembi, and potentially donanemab if it gets approved.
How often? Is there a recommendation on how often to do that?
Yes, there's an MRI we have to do soon before the treatment is initiated, within a few months, to make sure there's nothing new or surprising, brain bleeds or things happening already. And that's actually, just to mention, at this point, if we see 4 or more microbleeds at baseline, a person is not eligible to even take these medications because there's more of a risk of a bigger bleed. And so then for lecanemab, there's 3 MRIs recommended to be done in the first 6 months. And then subsequently, how do we know if the amyloid is being lowered in the real world when people are taking this? And so, so because it's just starting to be prescribed in the real world to a broader audience, that's not this very narrow, perfectly, defined research population that's in some ways very similar. We don't know exactly how often we need to do an amyloid PET scan, or maybe we'll do the blood tests when those are approved instead of the amyloid PET scan. But probably at a year, that might be the first time we repeat that. Yeah.
Are you ever sort of out of the woods? In other words, are these more likely earlier in the treatment and then less likely, or what's the time course of these things?
They do seem to occur earlier on in the first 6 months or so. As you're getting started on the medication, that is when it's the highest risk of ARIA. Yep.
And that's when I guess you're clearing the most amyloid out.
Exactly. Yeah.
Now, of course, there is a controversy here, and Dr. Steve Stahl and I did a podcast on this about the amyloid drugs and this, fixation we've had for 20 years or so on the amyloid and trying to remove the amyloid. But it does seem like it's a little further down the pathway or the progression of the illness. I guess they're still effective, and still this is a big deal. Is that correct? So
the way they're describing the benefits, the clinical benefits, I guess, if that's what you're asking, in the in the trial, say the lecanemab, the phase 3, is that in the 18-month trial, you're saving 5 months or gaining 5 months, right? And so 5 months doesn't sound like a lot, especially if you're like, okay, this 85-year-old person is going to gain 5 months of stability in their cognition and function. But we don't know over time, in the next 18 months, how much are they going to gain and how much are they going to gain. So it is sufficient enough to beneficial enough that it's, of course I'm biased, but I think I think that there is a group of people that deserve trying this, but maybe it's not as many people are eligible than generally is thought.
Well, 5 months to me sounds terrific for a chemotherapy drug, a cancer drug. They talk about extending survival rates by 6 months or so, and we get excited about that. So, that does make sense. Now, you mentioned another one in development, donanemab. Am I saying that right?
Yep, donanemab, yep.
Donanemab. Any differences in specifically how it works or anything from lecanemab?
Yeah, so it targets the amyloid plaques directly. It is very effective at vacuuming out the amyloid, so to speak, pretty quickly. And the way that trial by Eli Lilly was designed differently in that when they repeated the amyloid PET scan, at certain points, if the amyloid was normalized, they would, the person would, it was all blinded, the treatment, of course, but they would be changed to the placebo. And so then for a period of time, they'd be on the placebo. And then the repeat amyloid PET scan to see if, is it still normal or has it built back up? And so, again, we're still really on and looking at the data, and part of the huge challenge of these diseases is they move so slowly. But that is a difference. It is IV. It's once a month instead of once every 2 weeks. And their data sort of similarly shows that the benefits of these drugs occur actually, this is a really important point. They did something interesting when they were bringing people into the trial for the phase 2. They separated them into low, medium, or high tau groups. And so those they found who are in the low tau group to start have a better effect on clearing the amyloid and more slowing of cognitive decline. So that's pointing out that the earlier you get to this disease, the more effective the treatment will be.
So the tau is a little later, you're saying, in developing?
Correct. So in the biologically, you got the amyloid, say 25 years starting to build up before symptoms, and the tau is maybe 15 years before.
Okay.
And or maybe even closer to the disease symptom onset.
Okay. All right. So any real-world experience yet at this point? We've talked about the clinical trials. Are you hearing anything about how these drugs are being used or what people are seeing? Yeah. So Leqembi is being prescribed out there in the world, and I'm happy to hear that providers are being very conservative about it because, it is an infusion. This could be revenue generating. You could imagine some providers, enterprising providers might be who are not even in this field of brain, health would prescribe these things, but that's not really happening yet. And the systems are just starting to be developed in concert with infusion centers often. So you have community neurologists, for example, dipping their toe in it, prescribing this to, a few patients, working closely with the pharmaceutical company Eisai to make sure that this is all being done properly. You have to enroll a person, if you want Medicare to pay for the drug, you have to enroll them in a registry that exists, and so that's something different than we're used to. And so far, we haven't heard about any major, unintended side effects or deaths so far, and directly attributable to the drug. But it's just starting out. People are using the amyloid PET scans now to try to determine if, confirm the amyloid is present. But we don't have enough time to know, clinical benefits. Right. Are the amyloid PET scans fairly widely available? Like, would a usual neuroimaging center be able to provide those?
They're not readily available, so probably more in the bigger cities next to, and of course, specialty centers because of the tracer. There's only certain tracers that can be used, and
for that. But a regular PET or the FDG PET is more available?
Yes. Mm-hmm.
Is that correct? Okay. And you mentioned MRI without contrast. I was just curious why without contrast.
So typically, contrast can be used is better used to look for things like malignancy, tumor, abscesses, infection. It's not necessary to look for the kinds of things we're looking for.
Right. So things that are vascularized, it sounds like. Okay, that's great. Now, you mentioned something that made me think. You mentioned this registry, and it's interesting. I hadn't thought about this. There is not a REMS program specifically. Is that correct? Because we're used to some drugs in psychiatry that have these REMS programs, and yet it seems like that's a pretty serious complication, the ARIAs. Right.
So that's something that I personally think would be helpful to ensure safe prescribing and monitoring, but that ultimately the decision was made that wasn't necessary at this point.
Yeah, that's fine. It's not up to us.
Yeah.
All right. Well, let's, with the time we have left, and thank you, this is so extremely helpful, what you've said so far. Can we talk a little bit about what is in development, especially as our understanding of the pathology of this illness progresses? And you've already alluded to, we're starting to learn it starts 25 years before clinical symptoms. So what are some of the strategies or newer medications in development here?
So still certainly a lot to learn about the anti-amyloid monoclonal antibodies. Also looking at vaccines.
Yes.
Looking at anti-tau medications, anti-amyloid anti-tau monoclonal antibodies. There have been a number of trials in the past that have been negative, but we know that there's so much to good clinical trial design that is improving and having the right population, right dose, right time, right target, right. So that's improving. There's an anti-tau medication that's being delivered intrathecally, directly. Yeah. So the way a person would have a lumbar puncture, in their lower lumbar spine, they'll have the medication injected directly, and this is what is done with many brain cancers, right? So this is going to get right to the source.
Chemotherapy,
and this is in phase 2, and it looks like it looks like it's lowering the amyloid effectively, and then we have to wait and see if it's actually, tau. We have to wait and see if it's going to actually slow the progression of the cognitive and functional decline. While you kind of alluded to this, but while this field is very entrenched now in the amyloid hypothesis, there are now more things being looked at in terms of synaptic dysfunction, so the connection between the neurons, neuroinflammation, and thinking more about combination treatments is really probably what's going to be needed. And not just an anti-amyloid and anti-tau, but thinking more broadly. I would say something exciting that came out of the recent big conference, the Clinical Trials in Alzheimer's Disease, CTAD, was that the anti-amyloid, these similar drugs that have been, quote, negative in the symptomatic population, have been used now for years in individuals who are destined to develop Alzheimer's disease symptoms because they have these autosomal dominant mutations, like the presenilin 1 or 2 mutations, where they're going to develop Alzheimer's disease symptoms like in their 40s. They have a number of people enrolled in trials that they're getting an anti-amyloid monoclonal antibody years before they expect symptoms to begin, and they seem to be hanging in there longer than expected and not start developing symptoms and not having amyloid building up. And so that's obviously a unique population, but could that mean that, hey, we should, that's a big question. But that's exciting, and that points to could there be a cure? Like in the next 30 years, could we have a cure for some with Alzheimer's disease? So so those are some of the things that are happening.
Yeah, certainly. And you mentioned inflammation, also metabolism, insulin receptors and glucose metabolism is emerging. Yes. Even GLP-1 agonists. I know Novo Nordisk is studying semaglutide which then that would be really that drug. I think it waxes your floors, Dani. I think it does everything.
Yeah, it makes lattes. Yeah, it does.
Yes, it does. We know, of course, about the diabetes treatment. We know about weight loss. There's emerging evidence it's pro-cognitive and neuroprotective, and it's being studied. Our friend Roger McIntyre is studying these for mood disorders. We know that there's preliminary evidence on substance abuse and alcoholism, decreasing cravings. We learned about recently heart disease. So I think these drugs are going to get really widely used, and especially in psychiatry and neurology. So we're all very hopeful. It'll be wonderful, of course, if those trials are positive. And you mentioned some other really interesting things. I've seen some protocols recently for some really interesting drugs, as you mentioned, that worked on synaptic connectivity, that prevent neurodegeneration, inflammation, as you mentioned. Now, inflammation's funny because we know from mood disorders about 60% of patients with mood disorders have evidence of inflammation. I'd be surprised if the dementias don't pan out that way too, that anti-inflammatory drugs might work better for a subset of people. So it is exciting for us to develop biomarkers to be able to apply, as you mentioned, targets, the right drug to the right target.
Yeah, I see, again, to think about the cancer field, we kind of talk about maybe that cancer is 30 years ahead of the Alzheimer's and related. And so we're going to have such precision medicine that we'll have like receptor positive, these kinds of treatments and multiple treatments, combination treatment, and that Alzheimer's is really, 50 or 100 different diseases. So that's where we're headed. And I would just put in a plug for thinking about inflammation and metabolic changes. And this Alzheimer's starting 20 years before there's any symptoms. So where's the action going to happen where you're going to make a real change for your own life? Is midlife, what we can do now is aerobic exercise has strongly shown to slow the risk of developing Alzheimer's 20 years later. But what if we had an inflammatory drug plus exercise or physical activity in midlife? And wouldn't that benefit so many areas of our life besides just cognition? Yeah.
Absolutely. Well, there's lots of evidence about diet, of course, diet modifications, lifestyle, exercise. not smoking, managing blood pressure, cholesterol. I mean, all the kind of, like we would say, kind of boring standard things, not too sexy, but those things certainly. And then aggressively treating mood disorders, psychiatric conditions could certainly have an effect here as well. We know that many of our psychiatric conditions are not good for the brain and maybe a little more neurodegenerative than we realized. You also mentioned something else that I found fascinating, which is the idea of mixed dementias. We didn't talk about vascular issues too, but my understanding is that one mixes in with these as well. And so obviously managing cardiovascular risk factors could decrease that complication of this. That's
one. Yeah. So it clearly plays a role, and individuals who have both Alzheimer's plus significant cerebrovascular disease, have a quicker progression, quicker disease course, and more debility, of course. And so how to really prevent that, or much lessen that. Sure. And again, that goes back to midlife. And with mood disorders, the other thing I want to mention is that I thought of was, the isolation that often happens when we have mental health issues, and how that has clearly caused the dementias to progress more quickly. And so how does that all connect?
That is fascinating. You mentioned that, Dani. Roger McIntyre gave a terrific talk at Congress on loneliness specifically and all of the various effects. And loneliness is clearly associated with depression, with suicide. And I'm interested to learn, I didn't know this, in progression of dementias, which makes perfect sense. And we've obviously had an epidemic of loneliness, not just from the COVID pandemic, of course, but also social media is really having an impact. People are not getting together in person, having interpersonal relationships. They're having these, artificial virtual relationships. So that's another interesting thing that people can do, is pursue hobbies, pursue social interactions. The more social connections we have, probably the better for our brain.
Yes, so much can be said about that. And you just, again, if that was going to make some company tons of money to cure loneliness, right? Like, we'd all be out there. We wouldn't be even talking like this virtually. We'd be in the same room. Yeah.
Well, I'm not all anti-social media, but obviously one of the hopes with social media is that it would connect people and would bring us more together. But we certainly know the dark side as well. It's a double-edged sword. But I think that this loneliness issue has been very underappreciated. Everybody knows you should exercise more. Everybody knows we need to eat better. But I don't think we've talked enough about how to enrich our social relationships and how to combat loneliness. And especially, as you mentioned, as people get elderly, I'm seeing this in my own family, people die. Your friends die. You start restricting your activities. I can imagine for a caregiver of somebody with Alzheimer's, how incredibly constricted your life becomes. And of course, your primary social relationship with your spouse is changing. And you're not, obviously, as enriching. It's not as reciprocal, I guess.
Right. I think dementia it's not just a disease, it's an experience that goes on often for decades, and it's just totally just affects one's sense of self, identity, roles, relationships, causes so much grief, and it's just not even acknowledged or talked about, and there's often not time for a caregiver to spend thinking about this, but that's something that I think could make a big difference if we start having these conversations more.
Well, I agree. Well, I have to tell you, Dani, I have certainly enjoyed this conversation, and I appreciate our relationship, and I'm sure that this has been helpful for our audience. We are unfortunately out of time. There's so many more aspects of this I think we could have touched on or could have explored even more. So I'm going to ask that maybe you come back and we talk some more again in the future. And certainly we look forward to your speaking at our meetings, our Synapse and our Congress meetings. And for our audience, for more information on our various educational offerings, please go to our website, which is neiglobal.com. And Dani, I really want to thank you for joining me today.
Thanks for having me.
Oh, you bet. All right, take care, everybody.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.